Today, we're going to be going over information about what we already know about COVID-19 in the USA and beyond. And there is more to cover than what I can cover in our 75 minutes here. So I'll cover what I can, but we'll also be adding pieces to this puzzle throughout the entire semester. So in late December 2019, there was a cluster of pneumonia cases of unknown origin that were reported in China. And by the end of December, China had notified the World Health Organization of this cluster of pneumonia cases of unknown origin. And then within that first month, a lot of things happened. I'm going to point out some of them. Also, I want to note that figures like this, for example, are on Canvas. So you have access to these figures. You don't have to try and scribble things down, but you can simply follow along on those figures. So by the middle of January, this is a very important point, they were able to share the genome sequence of that virus with the World Health Organization. We would not have vaccines approved right now if it had not been for this critically important step that happened very early on in this pandemic. Of course, on January 12, 2020, nobody realized that over a year later, we would still be in this situation. And it is very fortunate and also a sign of the progress in science that so quickly they were able to get a whole genome sequence and provide that to others around the globe so that people could begin working on ways to deal with this virus. And it is in fact that genome sequence that people used to produce the vaccines that we are using in the United States. So it's a critically important step. Around that time also, you had the first case that was reported outside of China. This was very important because up until that point, everything was within China. I'll show you a timeline compared to another SARS outbreak, that the way we are interconnected and how much we move around the globe is actually part of what played a role in how quickly this became an issue everywhere in the world, right? So mid-January, we had the first case reported outside of China. And then by the end of January, most of the cases were still in China. I mean, we're talking about large clusters of cases within China and very few outside of that area. And yet, by that point, there were already places where the virus had been identified. There were 18 other countries that had identified cases of the virus. There's a question about where the slides are located on Canvas. They're within the module, so it's just underneath the Zoom link for today's lecture. You can access a PDF. Maybe Jen or Rose, you could double check that you can access the PDF. You should be able to, of the slides on Canvas. Okay. So how do I make this go away? Great. Okay. Okay, so after January, on the 11th of February 2020, the virus was officially named Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2. That's where that name comes from. So it's the International Committee on Taxonomy of Viruses that named the virus. You don't need to know the name of that committee. You don't need to know specific dates. We won't ask you for those sorts of details, but I think that it's helpful when we're thinking about the progress of what's happened in the world, as well as just getting you oriented to this information because you'll be seeing it on the news and you'll be an informed consumer of that news then. I want you to be aware of it within the lecture, but we won't quiz you on it. The reason that it was 2 is because there is another coronavirus that causes severe acute respiratory syndrome. In fact, there's more than one, and we'll go through that today. On that same day, the World Health Organization, which you'll often see as WHO, named the disease associated with that virus Coronavirus Disease 2019. That's why it's called COVID-19. Coronaviruses are a family of viruses that are named for their crown-like projections. It's a positive stranded RNA virus that will likely become important when we discuss vaccines. And to date, we know of 7 coronaviruses that infect humans, but there are other coronaviruses that infect other animals. So this is just a list from the CDC of the known human coronaviruses to date. Okay. There's a question about the slides on Canvas versus the slides that I'm showing. They do match, not every slide. So remember that it is lecture figures that are posted on Canvas, not every single slide that I post. So you are expected to take notes, as I mentioned last time. It's good to be an active learner. You should take notes about the big picture lessons that you're learning, but to facilitate that, when there are figures, I will post the figures in Canvas. Okay. And there's a question about the strains. Keep in mind that a different strain of a particular virus is not the same as having an entirely different virus. So we're going to talk about what we know about different coronaviruses at this point. Okay, and I'm going to go through the differences between these. So I'm seeing some questions about like fatality rate and that sort of thing. We're going to get to that. So within the coronaviruses that we know about, the first 2 to be identified are indicated on the screen here. They're very common. They cause a common cold. Many people have had them. And so for a long time, coronaviruses were not thought to be particularly concerning, because we knew that there were a couple that circulated regularly within human populations and weren't a cause of concern. But then in 2003, there was a coronavirus that was more concerning. So until 2003, coronaviruses were considered very mild. This picture looks like something that you might see on the street today, but this is actually a photo from 2003 when there was the SARS outbreak. So in 2003, a new coronavirus was identified that led to a severe acute respiratory syndrome. It was called SARS. We now refer to that as SARS-CoV-1 because we now have a second version, SARS-CoV-2. As David Wang described in his lecture in the Pandemic Science and Society, this SARS coronavirus that happened in 2003, when they sequenced it, they saw that it was divergent than the other coronaviruses that they knew about at the time. So, you know, it caused more severe illness, and it also looked, when you looked at it in a phylogeny like the one I'm showing on the screen here, it looked different than the other coronaviruses. That SARS-CoV-1 outbreak was believed to have originated in a bat, though it is unclear to what extent another animal may have been an intermediary between the bat and a human. And the way that it was responded to was with aggressive contact tracing and quarantining to stop the outbreak. Importantly, also, during that outbreak, the virus was only spread when people were symptomatic. So if you saw someone with symptoms, then you knew that they needed to be wearing a mask or quarantined. You could trace which individuals had symptoms, who they were in contact with. And that is a vitally important point, because as we get to talking about SARS-CoV-2, we'll see that it is different. So there are a lot of things that we should have learned from the SARS outbreak in 2003, including that we need very rigorous global health infrastructure. In that situation with SARS, there was an international transmission of a novel virus, and that really brought home the point that we need to be investing in our global health infrastructure. We also should be thinking about how we interact with wildlife and the rest of the natural world, and we should start changing how we do that. This is a conversation I'm having a lot now that we're in this COVID-19 pandemic. And, you know, these are lessons that we should be learning. Whether we will learn them this time or not, I don't know, but we certainly didn't after the 2003 SARS outbreak. We also should have learned the importance of contact tracing and quarantining and had systems in place that would allow for that to happen should there be another outbreak of this kind. Because it became clear with SARS-CoV-1 that an outbreak of a severe respiratory virus caused by a coronavirus was likely. And in fact, it has happened multiple times since. I will say that there are some positives. One of the things that has happened since 2003 is that we have had a lot of advancements in science. And, you know, it is notable that some of you were not yet born in 2003. I was actually an undergraduate in 2003. So to me, 2003 is really not that long ago. For some of you, 2003 was an entire lifetime ago. So I realized that we're coming at this from different places. But in the grand scheme of things, it is long enough that we should have made some important infrastructure changes and also a lot of scientific developments. But it isn't so long ago that we can't remember it for those of us who are, you know, older at this point. One of the great things that happened as a result of SARS in 2003 is that there was a lot of additional work on viruses and specifically coronaviruses. And so the advancements that we've had in science and especially genetic technologies have made being able to sequence a whole genome of a virus very fast now. This is a timeline of the outbreak in 2003. So, oops, sorry about that. Okay, so here at the top, there is the outbreak on the left side, the right side for SARS-CoV-2, and you'll see that very quickly within the first month, you have the first genetic sequence available. On the left, you have the first patient up here, and then you have to go all the way down. These are months passing. You'll see here, this is the legend to see how long this is. So each of these marks, these are months. The first genetic sequence available was all the way down here months later. So there have been some positives. We've had a lot of advances in science, which has helped us to be able to deal with this pandemic. And part of that also is because people have been working on identifying coronaviruses. So what you have here on the side of the screen is a phylogeny of different known coronaviruses. A lot of these are coronaviruses in bats. So you'll see at the top, there's a lot that are listed for bats. And these have all been identified and we know about them so that if they then make the jump into humans, we are in a better position to deal with them than what we would be if we knew nothing about them. So this means that we need to continue investing in research where we're looking at these zoonotic disease reservoirs and looking at the types of diseases they carry. Because with how we're interacting with the environment, we have a very high likelihood of having these diseases then cross into human populations. There's a question about if all coronaviruses are from bats. We don't know the origin of all coronaviruses. Bats have an interesting physiological makeup that allows them to carry viruses without becoming sick from them in a lot of cases. And so things like Ebola, as well as different coronaviruses, can be carried by bats. But you know, bats also do a lot of really important things for our ecosystems. So this has been a conversation in the past, like what if we just get rid of all the bats? There would be a horrible cascading effect of bad impacts for us, including uncontrolled disease vectors that carry other types of diseases. So for example, mosquitoes. A lot of diseases that we worry about now are carried by mosquitoes, and bats are one of the main animals keeping mosquitoes under control. Okay, just double checking the questions. So again, remember, you're not expected to write down absolutely everything that I'm saying. I want you to be getting an idea of the major points. I'm not going to ask you really specific questions about every type of coronavirus there is. You should be seeing that, this is an issue that we've known about before. This is not a random virus that we know nothing about, but this is part of a bigger family of viruses. Okay. So within this group of coronaviruses that infect humans, after the SARS-CoV-1 outbreak, there were two more coronaviruses identified that were similar to those first two in that they came with mild symptoms, they were fairly common in humans, and weren't really something to be concerned about. So at this point in the mid-2000s, we really just had this one coronavirus that was of concern. But then we had MERS. That's the Middle East Respiratory Syndrome. It's also like SARS-CoV-1 caused more severe symptoms. And actually in both the case of MERS and SARS-CoV-1, they produced worse outcomes for infected people. So they were more serious in the sense that people, when infected, had worse outcomes. What that means is that this current pandemic that we are in could be much worse, right? Every person who gets infected with COVID-19, with SARS-CoV-2 could actually have very bad symptoms and we could have a higher fatality rate. Fortunately, that is not the case, but that doesn't mean that it won't be the case in the future. So as we have seen now, every few years, we are discovering a new coronavirus, and every few of those are severe and have led to bad outbreaks. So this follows a pattern that is common with emerging infectious diseases overall, which is that in the past 50 or so years, there have been more emerging infectious diseases, which we'll talk about in a minute. And that maps very closely to the way that we are using the earth and the ways that we're interacting with wildlife, other animals, and the environment. Okay, so another point that I want to show you on this figure is that at the beginning of January, they shut down the market where many people assumed that SARS-CoV-2 had originated. So originally people were looking for bats that were the original host. They thought maybe a pangolin was an intermediary host. And so they shut down this market. But then when they went back and looked at the cases that occurred, this is from David Wang's lecture, they saw that the pattern did not actually fit with the market being the place where the virus originated. It doesn't mean it definitely wasn't, but it fits a pattern in which that market actually amplified the transmission. So maybe someone who had it went to the market and then it was an event that spread to a lot of other people, but not that it actually originated there. So what we have in this figure is that individuals who had some connection with the seafood market are labeled in pink, and individuals who did not have any connection with the seafood market are in blue. And these bars are representing multiple cases, right? So for example, this is one case. You can see the numbers on the side here. Here we have 2 cases that were not associated with the market and 1 case that was associated with the market. So if you look at this at the beginning, actually, the cases at the beginning do not look like they were people who were associated with this market. But there was someone who was, and potentially someone who originally became infected from wherever the virus did originate, then went to that market. And obviously there was a lot of transmission that happened at the market. Ultimately, all of those people then went back to their respective places, and you started to get this mix of people who did have an association with the market, people who didn't, and so on and so forth. So it isn't clear yet, actually, where the virus originated or in what species it jumped from non-humans to humans. This pattern of having these zoonotic diseases and trying to trace down where they came from is part of a bigger pattern, as I was mentioning. So COVID is an emerging infectious disease, and emerging infectious diseases are new infections to humans. So they may be things that have been circulating in non-human animals for a long time, but they're new infections to humans, or they're infections that humans have previously had, but that are now increasing rapidly either in their incidence or in the geographic range in which they exist. They are an increasing cause of mortality for humans that are for humans over the past 50 plus years. So starting in like the 1950s or so, we can track an increase, a steady increase in the number of emerging infectious diseases that appear each year in human populations. And many emerging infectious diseases are zoonotic in nature. So that means that these are diseases that can be transmitted to humans from other animals. So the way that we interact with animals and our environment impacts the number of these diseases that we're exposed to. The major concern that happens with zoonotic diseases is when there is a shift and the diseases are no longer only able to be caught in humans from other animals, but instead that actually they then shift to going to human transmission. That's what happened with COVID, right? So we don't have the pandemic that we have because people are constantly being reinfected from a bat or a pangolin or whatever it is. We have this pandemic because people are able to transmit the disease to each other. So that causes a lot of concern. Just checking the questions really quick. There are a lot. Yeah, great questions about figuring out the origins. The question about how common any of this is, I don't know off the top of my head, and I think also to some extent it varies. But you know, there are diseases that we still have to have that do not go directly between human and human. The types of diseases that are really concerning for this are respiratory diseases, because respiratory diseases, if they become transmissible human to human, then you know, as we have seen, breathing around another person then means that you can transmit the disease to them. But there are a lot of examples of zoonotic diseases that have become transmissible between humans. HIV is the big pandemic that we've been dealing with for several decades now. That's zoonotic in origin, and after it got into humans, then it became primarily almost entirely human to human transmission. There are two transmission events from non-human primates to humans, and otherwise you have a situation where humans are transmitting HIV to each other. Okay, so we need to be thinking about our interactions with the rest of the world. This includes wildlife, it includes domesticated animals. Huge factory farms are a common place to see emerging infectious diseases, or the recurrence of different pathogens that have not been of concern and suddenly rapidly increase in incidence within these big farms. We have to be thinking about our interactions with the environment, even beyond the effect of our interaction with the environment impacting our risk of zoonotic diseases. There have now been studies that show that air quality in the neighborhood where you live or where you grew up is associated with the impact of COVID-19 on your body if you get infected with it. So there are all sorts of things that we're doing to our environment that are linked to how healthy we are. This is called the One Health approach, where if we want to be healthy as human beings, we cannot ignore the health of other species or the health of our environment. They are intimately linked, and the only way for us to truly be healthy is for us to actually take care of the health of the environment and other animals. Okay, so I mentioned that SARS-CoV-1 spread between people who had symptoms. SARS-CoV-2 / COVID-19 is very difficult to deal with because there are high rates of asymptomatic spread. And also because there is a long incubation period. You may have heard that if you're exposed to the virus, it could be 2 days or it could be 14 days before you experience any symptoms. It could be the case that you go more than 14 days, never have symptoms, but it turns out that you were actually infected with COVID because there's so much asymptomatic, there's asymptomatic spread, but there are a lot of people who are asymptomatic with COVID. So what does that mean? That means that in the past, things that we tried to do, like reserve masks for sick people, is not a good or effective approach, right? We should not only have people who are sick wearing masks. In fact, everyone needs to wear masks. This obviously led to some issues at the beginning of the pandemic when there was very mixed messaging about who should be wearing a mask and how important masks are. We now know everyone needs to be wearing a mask all the time unless you're in the comfort and privacy of your own home. It means that if people aren't proactive about taking precautions always, not just when they feel sick, but always, then they increase the likelihood of transmitting the disease within their community. It also means that individuals cannot decide if they're safe or not to socialize because having symptoms doesn't mean much of anything about if you are actually sick with COVID or not. So this asymptomatic spread is very important. It's very problematic. It also means that it's harder for medical professionals to detect who has the virus because all biological tests have some rate of false negatives. That's just true about all testing. I know people have lost their minds at the idea that COVID tests could have false negatives, but that's something that we've known about biological tests for a long time. Often in a biological test, you, especially for medical purposes, you can use symptoms as a way to cross-reference what you find out from the test. That hasn't been very useful with COVID because often people have COVID and are not showing any symptoms. That testing issue becomes even more complicated because of the long incubation period, and I'll get to that in a minute. So what this means, so by the way, if you're currently frantically trying to scribble down all these words, please don't. There's a high rate of asymptomatic spread and a long incubation period, right? All of these other things about the fact that you should always wear a mask, don't decide when you're okay to socialize, all of that. You don't need to write that down word for word. But hopefully you will remember that big picture item that the asymptomatic spread means that you always have to be taking precautions and you can't decide that you're safe just based on checking your symptoms. So this long incubation period also means that people have to be cautious for long periods of time. So for anyone who's been exposed, they need to quarantine for a longer period of time than you would have needed to with other viruses before they know that it's safe to interact with other people. But the long quarantine periods have been something that it's been really hard to get people to actually do. It's been so hard, in fact, that the CDC changed their guidelines. And if you read their guidelines, they say 10 days, and then they say, please note that the quarantine period should be 14 days. But we are saying you can do 10 days provided that you do X, Y, and Z. And we would like to also note that even if you do all those things, we still think that there's a chance that you might have COVID if you don't wait the full 14 days. So, you know, the pressure of the public to not actually quarantine for so long has been a real problem. And in some cases, that makes perfect sense because we don't have great social services. And so some people don't have the opportunity to quarantine for 14 days when they aren't getting paid for those 14 days. It also means that that testing gets further complicated because when do you test if you have this long incubation period? There's been a lot of changes in this. You know, there's a recommendation to test at day 7 and then again at day 10. Some facilities are just testing at day 8. There's a lot of variation in the post-exposure testing, and that has to do with the fact that there is this long incubation period. Okay, and then on a non-virus physiology note, I'll just mention that the human brain does not process exponential growth well. So I think another complication of SARS-CoV-2 and the COVID-19 pandemic is that people are having trouble recognizing the cascading impacts of their actions. So let's talk about that for a little bit. So our brain is used to processing things that grow linearly or, you know, accumulate over time. It's snowing today, so the snow accumulates over time. This is something that Dr. Zaks talked about in the Pandemic Science and Society. And he said, I think something that helps point out how complicated this is, that with exponential growth, not only does the rate of growth increase, but the rate of growth of the rate of growth increases. And trying to get people to wrap their brains around that is complicated. He also pointed out that anchoring our predictions for the future on what we see today is problematic. So for example, if today 10 people are infected and you think, oh my goodness, today 10 people are infected, that means tomorrow there could be 10 more people infected. That's actually not what it means. It means that tomorrow there could be 100 new people infected. And so if we're anchoring it based on what we're seeing today, we're automatically going to underestimate what we might see tomorrow. There are also social influences that impact our reasoning. Even if as individuals, we know COVID is not a hoax or that people really can die of COVID, if we're in a social situation in which people are repeatedly saying that's not true, that can cause, even if you still know COVID is real and COVID can kill people, you know, it just starts to make you question some of the things that you hear. So those social influences can impact your reasoning. But the good news is that visual aids can really help us understand the rapid spread of COVID-19 and also how to reduce the spread. And some people have been able to use these data and also data visualizations in a really effective manner so that they can slow or stop the transmission of SARS-CoV-2 in their communities. We haven't obviously had great success of that, despite the beautiful visualizations that have been produced in the US, but you know, there are some places that we can see positive examples of that. I'm just gonna double check the questions, and I'll just remind people about that questions should be appropriate. Thank you. Okay, so there's a question about data from other countries, and I think that's a great question. There are some countries that we don't have a lot of data from, so I think that that's an issue, but I think that there are plenty of countries that we do have reliable data from, and I'm going to show you some comparisons of different countries around the globe. There's a question about, are all future pandemics likely to be caused by something from the coronavirus family? No, that's just one of, you know, a large menu of deadly viruses that we could be dealing with in the future. You know, I work in East Africa. I work in the western side of East Africa, very close to Congo, where there have been multiple Ebola outbreaks. So Ebola is one that I often think of. That's a hemorrhagic fever. There are a number of different hemorrhagic fevers that are an issue, that have been an issue that, you know, if they spread rapidly around the globe could be of serious concern. So yeah, there's a lot of different, Zika virus also is a different, a third then type of virus that we're talking about, similar to yellow fever virus and dengue. So there's a lot of different viruses that are more than ready to do destruction to us. Someone asks, what exactly is an incubation period? So that is a period of time between when you would be exposed potentially and when you might actually have a physiological response from the virus. So a lot of times we would normally expect that to be symptoms, right? So the incubation period would be the time period between when you get exposed and when the virus replicates in you enough to cause you symptoms. But with COVID, the virus can actually replicate inside you and not always cause symptoms. So, but there can be a point in which you would be able to detect the virus, and that's that incubation period. Okay, great. So I'm just trying to keep up with some of these. Obviously, I won't get to all of them, but all right. So speaking of data visualizations, I want to show you the numbers. I did this with the pandemic class where I showed the first day and the last day. And you know, I look back now and think, how sweet was I that I was so shocked by the numbers as they changed in those 3 weeks. So the first day of the class was the 17th of August. For now, I'm going to show you the data from Missouri. And by that point, the virus had been in the United States that we knew of for, 5 months or so. And so then more than 6 months anyway, since the beginning of the year. And so we in Missouri had over 68,000 cases and 1,400 deaths. Within 3 weeks, at the end of the course on September 4th, we had over 90,000 cases and over 1,600 deaths. So even in a short time period, we were seeing a lot of individuals impacted from the virus. And then if you look now, Missouri has over 485,000 cases and over 7,000 deaths. Looking back at that time in August and September when we were in the pandemic science and society class, this is just very low. I mean, the scales are even different on these. On the left side, the scale is in 1,000 cases. And here we have an upper limit of 6,000 cases, even surpassing 6,000 cases on some days. So what I want to just orient you to these because I'm going to be showing you these same visualizations for the US and also the world. Each bar is for a day. So these pink bars are showing the new cases that day. It's not the accumulated or the total number of cases that have occurred, but just the number of new cases in that day. And then this red line is the 7-day average. So if you look at how many new cases there were in a 7-day period leading up to that day, the average is what the red line is tracking. So sometimes, you have new cases, new case days that go above the red line. Sometimes they're underneath because it's an average. If you want to know the total or the accumulated cases and death, you look at the numbers. So each graph is showing new cases. The numbers are all showing the totals. Okay, so obviously we did not get things under control. We continued to have a lot of new cases. Okay. So worldwide, we've seen a similar pattern. On August 17th of last year, there were over 21 million total cases and over 775 deaths. Just 3 weeks later, there were over 26 million cases and over 868,000 deaths. And now, we are less than 5 months after we have over 100 million cases and over 2 million deaths worldwide from COVID. There is obviously a lot of difference between the different countries and how much they're dealing with COVID. So this is a graph, or a map, which has countries that have higher cases and death rates currently in a darker purple color. So basically, the darker the color gets, the worse it is. And so it's a hotspot map. So you can see here that the United States is a hotspot for COVID-19. With a lot of Ebola outbreaks, for example, we would often see countries in Central Africa being hotspots. Now we're seeing that there are a lot of European countries, also the United States. Brazil has also had a lot of issues with COVID. So these are the hotspots. You will see that there is a ton of variation across this map. Different countries are having different experiences with COVID. So if we look at the United States, which really has been leading the way, basically this entire pandemic, on August 17th, there were 5.4 million cases in the United States and nearly 170,000 deaths. 3 weeks later, there were over 6 million cases and over 186,000 deaths. And now, again, keep in mind that these scales are changing. So this is 50, these are by 50,000 cases. Here we have an upper limit of 300,000 cases per day, right? And so you can see that we went through a period recently in January where we had several days where we were peaking out at 300,000 new cases a day. We now have a total of 25.4 million cases of COVID-19 in the United States and over 425,000 deaths. So when you look at those numbers in the United States, it is easy to think that's fine. Some countries might be able to get this under control if they had warning at the beginning and they, it never got that bad. But with an asymptomatic virus that is spreading through respiratory droplets and aerosols, there's really no way to control COVID-19 without a vaccine. And so my question is, do you think this is true or false? And you can go ahead and put your answers in the Q&A. At this point, is a vaccine our only hope? Okay, good. I'm seeing a lot of false. So yeah, I mean, one of the concerns about this pandemic is that from the beginning, a lot of people have been sitting back and saying, I'll wait for the vaccine. And it is a scientific masterpiece that we have vaccines right now. I mean, I was not expecting that. The vaccine development process is a very long process. Fortunately, there were a lot of things that went right for this vaccine, including that people had been studying coronaviruses for a long time, and people had been studying mRNA vaccines for a long time. So we were fortunate in many ways, even to have a vaccine right now. But it's a problematic path to take, because here we are a year later with some people still expecting a vaccine to save us. And the reality is that you still have to wear a mask. You still have to keep your distance. You still have to avoid gatherings if we want this vaccine rollout to be effective. And that's because there are other variants of SARS-CoV-2. And so, yeah, it's false to think that there's no way to control this without a vaccine. Some countries have been quite successful. There have been a lot of examples in the news and other places of countries that have done a really good job of controlling their COVID-19 transmission. These countries did not all take the same approach. There isn't like a magic list of things to do, because obviously there's a lot of variation between countries. Some of them are very small, some are very big. You know, different countries have different social services, so on and so forth. They all didn't have the same experience. There was at some point people talking about, well, countries that had SARS-CoV-1 previously knew how to handle it better, so they did fine. It's not all countries that had to previously deal with SARS-CoV-1, but all of them did certain things right that allowed them to be successful. So some countries did learn from previous outbreaks. Some countries already had systems in place to handle something like this. Some had very thorough testing and tracing systems that allowed them to accurately identify and quarantine as needed. Some countries have created a good culture around wearing masks, not going around people during times when you could potentially get them sick, or, you know, when there's a pandemic that could kill everyone. And some of them, okay, it's not going to kill everyone. I know that some people, that was a slip of the tongue. Okay, some had effective lockdowns, and part of an effective lockdown is having good social services. So, you know, the idea with a lockdown is not just to tell everybody, stay home and fend for yourselves, because obviously we need to be able to provide services to people who need them in a lockdown. And another thing that they had is strong leadership. So having at some level in their country, people who were using data to make decisions and then working effectively to try and prevent the transmission of SARS-CoV-2, there are success stories where this has worked. So it is possible. One thing that we learned about dealing with a crisis is that you have to actually recognize it. If you don't recognize that there is a crisis, then it definitely won't get handled. And that's something that Josh Sharfstein talked about in terms of managing a public health crisis. So the first step, recognize that it's a crisis. You have to do that so that you can then implement the measures necessary to be able to handle it. Also, don't necessarily assume you can fix the problem in the same way you have in the past. You have to look at issues in a new way. So, you know, this is something like the example of masking. If you are trying to treat a disease that has a lot of asymptomatic spread the same way you treat a disease that has only symptomatic spread, that's a problem. You need to have one leader who takes control of the situation. And then that leader needs to be very organized and delegate tasks and have other people taking control of the situation. And those decisions should involve data, which apparently I'll get to in a minute. There should be clear communication, and actually that communication is a life-saving intervention. I loved when Dr. Sharfstein said that, you know, it's not always about having a medicine that saves someone's life. It's not always about having a vaccine. Sometimes just effective health messaging that tells people what they need to do to keep themselves safe and creates a situation in which they can do that, that is the intervention that can save lives in itself. And then you need clear recommendations that are based on data and science. And you also have to be willing to then report the data out to people so that they can use those data to make decisions also. So when we look at this map again, you know, I'm surprised to see some of the countries that are in pale colors here, like India, for example, like China, where the virus originated, because that's not what we would expect given what we've seen of issues there before, which is that they had massive outbreaks. They had a lot of cases. So if we look at this list that shows places that have low rates of SARS-CoV-2 and are continuing to keep low rates, you'll see a lot of big diversity of different countries here, from Africa, from Asia, from Central America, Australia, Papua New Guinea, mainland China is on here, right? And we know that most of the cases at the beginning were in China. Another one, this floors me, India. I don't know if all of you have been paying attention to the COVID news as much as I have, but in the fall, India was rivaling the United States and Brazil for the worst situation with COVID. They were in a very bad place. And that's something that people were predicting, the catastrophic outcomes that would happen in India because of how bad the numbers looked last fall. And it is shocking to look today at the numbers from India. If you want to think about, can we actually get this under control given how many cases we have in our country? If you look at India, the answer is apparently yes. Here you have this sharp increase in cases. This is following a pattern very similar to what we saw in the United States, maybe slightly delayed from what we saw in the United States. But then they have effectively gotten this down. I saw a report recently that they think they may have their COVID outbreak under control by February, which is right around the corner. Obviously, as someone in the United States, that's shocking to me. India is a very big country. So sometimes people say the US is so big, it's hard to, manage this. India is very big. India is very diverse. It has many different languages, many different cultures, many different religions. I've traveled a lot of places, and India is one of the places where being there, I've had trouble wrapping my head around it, actually, because it is beautiful and diverse and has just a lot of variety of life in many ways. It also is a place with extreme wealth and extreme poverty, which we have in the United States as well. So this gives me some hope that it is possible that we could implement strategies that help us to be successful. And that is the key. There are intervention strategies that interrupt transmission. And if we can actually create a culture of using those strategies, then we can get this pandemic in the United States, at least, under control and hopefully elsewhere. Yes, okay. So there is a comment that perhaps we should be cautious about the data in India, which is fair. And I will look into that more, and we can talk about India more in the future. But India is not the only example of this. It is one that sticks out to me because of how bad it was in the fall. But there are lots of countries, other countries in that list that you could see that had higher case rates last year and are getting the situation under control. So that is worth keeping in mind. Okay, so in order to have good intervention, we must remember the 3 modes of transmission: droplets, aerosols, and fomites. Remember that for droplets, where it's literally you talking, you sneezing, you coughing, and having little droplets of wetness come from your face and then land on someone else's face, or come from someone else's face and land on yours. In order to prevent that, you need to keep your distance. You need to wear a mask and also eye protection, particularly if other people are not wearing masks. You should wear a face shield or goggles, safety goggles or glasses. And that also means even when you're outdoors, droplets can spread between people standing in close proximity, talking, eating, etc., when they don't have masks on. So being outdoors does not necessarily save you from having that happen. Aerosols, which are the accumulation of those, little wet particles from your mouth and in your breath, that can build up in an indoor space, even if you're not standing in close proximity for someone to be able to get a droplet directly on you. If we now know, are in an indoor space where the air can build up, it's not well ventilated, then you can become infected because of aerosols. So you need to avoid public indoor spaces, wear a mask that fits properly. I have a slide on this in a little bit. Reduce your time indoors with others, and don't spend time indoors with people who are not wearing masks. And then for fomites, you need to remember to wash your hands. Don't touch your mask, your eyes, your face, your mouth, or anything with unclean hands. Okay, so at the beginning, there was not a lot of focus on aerosol transmission. There was a lot of focus on wearing a mask, keeping your distance, yada, yada. But then obviously there were a bunch of people who reported about the concerns about aerosol transmission. And then a focus really became on avoiding indoor spaces that are not your home. So it is important that we continue to do that. Avoid indoor spaces that are not our home. Avoid wearing a mask that doesn't fit well. You want to wear a well-fitted quality mask. And, you know, this issue will continue to be important with these new variants. From what they're saying about the new variants, it seems like avoiding indoor spaces and wearing a good mask and having other people wear a good mask will really be key to keeping our transmission rates low. Okay, someone asked, what is a fomite? So those are just objects that are contaminated. So that's the idea of washing your hands, right? If you're touching a surface that somebody else may have sneezed on, coughed on, breathed on, anything else, and then you're transferring what's on that object, whether it's a coffee cup that you're holding or you know, a desk that you touch, when you transfer that to your face, you can be exposing yourself. Okay, so you want to make sure that your mask fits properly. This is a slide from Dr. Jimenez, who talked to us in the Pandemic Science and Society. And these images are showing the leakage of air around different masks. The idea here is that you want to avoid gaps. And he said, you know, take time, look at yourself in the mirror, check out how your masks fit. You want to have that nose option to really tighten down around your nose, along your face. You want to make sure that the sides are pressed tight against your face. You know, you can have ear loops or a tie, however it fits best for you, for it to be very flat against your face. And, you know, they make all sorts of cloth masks like this, where you can adjust the nose covering and also adjust the ear loops, so on and so forth, and make sure that it's a good fit to your face. You also want to make sure that they are good, high quality masks, that you're not using, you know, like a gaiter or something. That's something that's not recommended, but that you have sufficient protection around your nose and mouth. And also keep in mind that droplets are still a concern. You know, I walk my dog a lot, and so I see lots of people interacting outside. And because they're outside, they seem to think that it's like a magic space and they don't have to wear a mask and they don't have to keep their distance. And that is not true. There are different modes of transmission. And even when you are outside, you have to be concerned if you are too close or if you aren't wearing a mask. It amazes me when I see construction workers or city workers who are doing construction work, and they'll be wearing hard hats, yellow vests, all sorts of gear, just piled on with gear. And then they'll be standing, talking to each other face to face like this without masks on. And it's like, I'm positive if you could remember all that safety stuff, you could remember a face mask. And as someone who works in a field where you have to wear face masks while doing very like energetically difficult things, I know that it's possible to wear a face mask while doing physical activity. So yeah, if you're outside, you still need to keep your distance and or wear a mask. And then I think it's also important for us to remember that inequality is a big concern in this pandemic. There are differential impacts of the COVID-19 pandemic on different members of our society. At the beginning, people were saying, stay home, everyone has to stay home. You know, that's not possible for an essential worker. And many essential workers aren't doctors, right? They're minimum wage workers who fill grocery bags and things like that. So we have to be careful to remember that whatever situation we are in is not the same situation that everyone is in. Wear a mask is a great piece of advice for those who are able. But it's not possible for everyone, especially if, for example, there's someone with specific medical conditions. And I understand that you may be thinking every single one of the construction workers that I see on my walk has a specific medical condition that allows them to do construction work, but not wear a mask. And that may be the case. And then I'm wrong for saying they should wear a mask. But, you know, there's also, could be better messaging around the fact that outside people who are able should be wearing masks. There are families with children where the parents are essential workers and the kids are supposed to be schooling from home, right? You hear about this a lot where you have kids, 7-year-olds that are supposed to be doing their homeschooling while their only parent or both of their parents have to go to their job. The effect of this pandemic on different people in our society has been drastically different. There are large disparities. So this is a graph of deaths per 100,000 people by race or ethnicity. And you will see here at the top that Black, Indigenous, and Latina people, Latinx people are more likely or have more deaths per 100,000 than, for example, down here, we have white people, right? And I could show you 1,200 different graphs about this. There has been a lot written about this. There have been a lot of different visualizations about this. The people are being affected by COVID in very different ways. And the reasons for this are many. There are layers of disparities that lead to these results. So it's not, it's not just about race and ethnicity, though it is also about race and ethnicity. It's also about all sorts of historical issues. Essential workers include minimum wage workers. Those workers include things like people who work at grocery stores, people who work in the meatpacking industry. The meatpacking industry in particular, we know that there is a large population of both immigrants and Latinx people that work in the meatpacking industry. There is an overlap between people who are making lower wages and having poor access to healthcare, poor access to healthy foods, poor access to other types of resources, and also minimum ability to take off work. So there are a lot of compounding factors that are impacting why we see this difference. So so there's compounding impacts of these inequalities, and that leads to not only sorry, my dog's barking, not only differences in the number of deaths that we see, but also the number of people that get sick with it, the number of people who have long-term health impacts from it. And so we need to be concerned not only for ourselves, but on other members of our society who are suffering greatly from the pandemic. This is also a concern for vaccine distribution. We're going to talk about this more later on in the class, but you may have seen that there are different tiers for different people to get the vaccine. This food and agriculture sector, also I would say another area hard hit is the transportation sector. So people who are driving the trains, driving the buses, those sorts of things. They both fall under phase 1, that seems positive, phase 1B, that maybe seems less positive, phase 1B tier 3. Okay, so you've got educators and childcare, K through 12 educators and younger childcare faculty members within this tier also. So people who are doing really critical things for our society, educating our children, supplying our food, making sure that our transportation systems are working. They are in phase 1B tier 3. Let's not, judge this category by its name. Let's look at what that means. Okay, so who's before phase 1 tier 3B? Sorry, phase 1B tier 3. Phase 1A is patient-facing healthcare workers and long-term care facility residents and staff. By the way, this is for Missouri. The other interesting factoid about the vaccine distribution is that it varies by state. So this is for Missouri, and the phase 1A is our doctors, nurses, long-term care facility residents and staff. Wonderful, because obviously those are not only people who really need the vaccines, but also that helps facilitate getting the vaccine distribution going to people who are already at the facilities where they'll be distributing them. So that's great. Phase 1B, so now we're in the phase 1B where those food and transit workers are listed. Tier 1, first responders, emergency service, and public health infrastructure. Okay, another important group of people to get vaccinated. There is an issue in here, though, of course, which you may have heard about in the news, which is that non-patient facing public health infrastructure employees are included in this. So if you work at a med school, you do research, you teach, so on and so forth, you're included in that. That has brought a lot of concern because obviously there's a lot of privilege in those positions that someone who's stocking shelves at a grocery store, for example, and seeing hundreds of customers a day does not have. Phase 1B Tier 2 are high-risk individuals, and you may be thinking, okay, we're getting somewhere here because we just saw this graph of how some people are at higher risk of dying or being infected from COVID based on their race or ethnicity. But I have asterisks here because I want to point out that in these terms, high risk is based on age and pre-existing health conditions. Obviously, those are really important, and we want people in those categories to get access to the vaccine very soon also. Okay, and then after that, Tier 1, Tier 2, then you have the tier where we're gonna get teachers, we're gonna get food, anyone working in the food sector, or at least people working in some parts of the food sector and transit sector. One thing that's concerning about this part of the distribution is that, sorry, my computer's dying, so I'm gonna plug it in, is that there is this warning up on the Missouri message board related to COVID-19 that there is an exceptionally limited supply of COVID-19 vaccines. So obviously when you're thinking about people who technically qualify for getting the vaccine, but obviously aren't under the sort of conditions that some of our minimum wage workers are, that becomes a concern. Who's below phase 1B Tier 3? That's also an interesting category, and I'm in that category actually down here as a higher education faculty and staff. Honestly, I don't know that I even deserve to be in this category. I do run a lab that I have to go into in person. I deal with students in person in that lab, but I am very privileged to be able to do a lot of my work remotely. I'm in the same category as disproportionately affected populations, which are what we were talking about before with that graph, and the homeless. And I would say that these people should be way above me, as should, the people who are in the tier just above me, which is that food and transit workers. Oh, how do I move to the next one? Okay. In fact, disproportionately affected populations and the homeless are just above phase 3, and phase 3 is everybody else. That's the end. It goes from disproportionately affected populations, homeless, and then everybody else, and then we're done with vaccinations. So obviously you will be hearing things about concerns over inequality with vaccine distribution. It's something that people are talking a lot about as it fits with larger inequities within our country. So, some of those things are things that we can keep in mind when we're trying to think about how to deal with our behaviors in relation to this virus. Maybe you feel comfortable taking a risk for yourself, but do you feel comfortable with what that means for other people? And, think about the privilege that you have to reduce transmission for everyone. All of us in this class are facing different issues. I acknowledge that, and I realize that I have a great deal of privilege, and I appreciate that. But all of us that are on this call right now have the privilege of connecting to each other over an electronic device. And one thing that we learned early on in this pandemic is that that actually is not as common as we once thought it was in the US. There are, upwards of half the population that does not have access to an electronic device or reliable Wi-Fi to be able to interact in this way. So remember that others may be dealing with very serious issues, and to what extent can you use, your ways to connect and whatnot, and do things virtually to try and help ease the burden on the entire community. We have racial inequalities in health, wealth, and beyond. And I think actually that I'm going to pause here to answer some questions. I have more, but I clearly planned too much for this lecture. So we will carry this forward to the next time. And some people are asking about differences in specific people getting vaccinated, right? Like, for example, we saw lots of videos of people in government getting vaccinated, and someone pointed out that government is tier 3. Okay, and so this further leads to discussions about inequality in vaccine distribution. So we will talk about that again in the future. So there's a question about how much the US COVID response has changed with the Biden administration. People are still, I'm actually in trying to plan this class, I'm kind of waiting to hear back from some people that have offered to speak to the class about their schedules once they're appointed, who will be part of the COVID response. And, part of the issue is that those appointments are still happening. So I think that they kind of hit the ground running, making some big changes early on. But in terms of having all the team in place and really making the sort of changes that we'll see throughout the country, I don't think that that's happened yet. It's been a week. So I hope that we see that. I hope that people learn from what's happened over the past year. But the vaccine rollout, for example, is state by state. So it's not just what's happening at the federal level. We need strong leadership within our state. And we need to have a good plan within our state even. Perhaps that will change. I don't know. And I'm certainly not an expert on policy decisions. Okay, so we are now at 3:45, so I'm going to stop here. There are more questions. We do keep track of all of the questions. We may start some discussion boards about topics that you all are particularly interested in. Of course, you can also come to our office hours, and I'm happy to follow up with people as well. So for now, we're going to pause here, but we'll pick this back up next week. I hope that you all stay warm in this crazy snowy weather if you happen to be in St. Louis. I look forward to talking to you more about SARS-CoV-2 and COVID-19. I will see you all next week. Until then, stay safe.